This
Tuesday.
conference will now be recorded.
It's Tuesday, December 31st, 2024. Happy New Year and welcome to the AnCan virtual support meeting for high risk, recurrent, and advanced prostate cancer. Thank you all for joining. If New Year's means anything to anybody, it means something to us. I'm moderator Ben Nathanson, and I'm joined by moderators John Antonucci and Rick Davis, the founder of AnCan. Len is not here tonight. He writes, "We always celebrate New Year's Eve at sunset on the beach and don't leave the beach till after 7 and after a few drinks of Prosecco," which begs the question, what are we doing here? You'll hear medical issues discussed tonight, but we're just a bunch of guys. Nothing you hear is medical advice. Funding for the meeting comes in part from these sponsoring companies, whom we thank but do not serve. We thank Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, and Blue Earth Diagnostics. Is that an up-to-date list, Rick?
I think so, but I would like to add it's very appropriate that it also comes from you guys, and they have been, some of those sponsors have been a little lax in the past year, and so we thank everybody who has already participated, but we hope all of you who haven't will participate, just to show your gratitude for what we do almost every week. So please think about donating. You've had enough reminders in your inbox. And also, if there's anybody on here who hasn't finished done the survey, I will momentarily post the survey in the window. We're almost at 400. So we're going to call it a day at 400. I think we need about another 5 to get to 400. Thank you.
Luther, do we have time to do an intake, or do you have to go right away?
No, I don't need to go. I'm just saying mine is a low priority because it's update, so feel free to bump me.
Okay. Dave, are you still here? Dave, the new guy? It's hard to hear you, and we don't see you.
Hold
on. My dog's working on it.
There you go.
Excellent.
Luther, have you been in this big group before? I can't remember.
Yeah, I have. But
okay.
I haven't come for a few months, Rick. I think I came twice.
Okay. So we did do an intake with you.
Yeah, and I'll be at the small group next time it happens too.
Yeah.
I just figured I'd pop in today.
It's great. And I see Luther once a month in the under 60s group. So So and what about Mr. Boga? Is he new?
Yes, he is.
Yes.
Oh.
Okay. So you have 2 new gents, Mr. Boger and Ethan Boger and Dave, but not Luther.
So Dave, welcome to the group. What is your last name, Dave?
Villegas.
Could you spell that?
Uriegas.
So where do you live?
Outskirts of San Antonio, Texas.
And how old?
72.
I guess you just don't. 72?
Yes.
And you were just diagnosed. Is that correct?
Yes.
When were you diagnosed?
I believe they let me know on December the 23rd.
Mm-hmm.
Give me a biopsy, and then they gave me that stuff where they shoot that the radiation in you.
Mm-hmm.
That smear, what do you call it? And then the 23rd, they let me.
Hang on. So what led you to think you had prostate cancer?
I've been going to see this doctor for about 6 years, because I had an infection one time, and they've been keeping up with it. And then this last June, it turned out my PSA was high, and I thought it was just another damn infection.
Mm-hmm.
So he said, let's give it 6 more months and give me some
Ah,
antibiotics. But after that, it didn't happen.
I'm sorry.
Yeah. He said that
So,
he sent a
uh,
CD, and they said that I had cancer in my lymph nodes and prostate.
so what was your PSA when you were
I
diagnosed?
think it was 80 something, I think.
Jeez. So you say you had a biopsy,
Yeah.
and did you have an MRI scan as well?
No, they got a PET scan with a
Okay.
CAT scan. I mean, a CT.
Uh-huh. Uh-huh.
Yeah, that's when they found out all the images of when they put that dye in you, and they showed up all the places that cancer is at.
Mm-hmm. Mm-hmm. So you know for sure it's a PSMA PET scan?
Yeah.
Okay, excellent. So are you deciding on a treatment? Have you
Well,
decided what treatment you're going to
that's the
get?
thing. He was pushing this program that he said there's some new pill stuff, and I supposed to cut off your testosterone, pumping it to your prostate, and that will stop pushing it to the lymph nodes. And then he suggested that I get into this program where it's an experimental program to where they give you one proven pill and the other one is 50-50, you know what I mean? Could be a sugar pill, you know what I mean? But it
Where are you
said it
getting
control it that way.
were you getting treated?
Right now, I've been taking the pill for the testosterone, what do you call it? It's not
Who is
pumping it no more, whatever.
who is your doctor?
De la Celta, Jose
And
de la Celta from San Antonio.
and he's a urologist.
Yes, sir.
So you're not going to have radiation or prostatectomy. You're going to have an experimental treatment.
Well, that's the thing, I've had cancer on my vocal cords, that's why my voice is messed up. And I got treated with radiation. It seemed to work, you know what I mean, 30 years ago.
Uh-huh.
And this guy just said, let's go experimental. And I says, I don't know what
Yeah.
the best one would be. Will it hurt me more getting radiated down there or what? I don't know.
Right. 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 Yeah, it's good you have questions. Um,
And somebody suggested chemo. So I said, I don't know, man, what's best, radiation, chemo, or pills. You know what I mean?
Ben, Gleason score?
he said that it was like in the 80s, did you say?
No, that's PSA. What was his
Oh,
Gleason?
oh
Oh,
yes.
nine, nine.
Did you learn about this on
Oh,
Mayo Clinic? Is that where you learned about this place, Dave?
No, my daughter did. She's been
Okay.
researching stuff, my kids.
let's go back to Ben. Go ahead, Ben. Let's finish up and then we can come in with all our questions.
So you live in San Antonio?
Yes, sir.
And I'm sorry, did you just yes, your daughter learned about this? How did she learn about this group?
My daughter.
Yeah, she's the one who told you about AnCan?
Yeah.
Yeah, just through this. Through the website.
Hmm.
Just through the website.
Yes, they got a website on the paperwork that they gave me at the doctor's office, I guess.
Oh wow. Um,
Your daughter can participate. She's very welcome to come in. We love having care partners in there. Hello, lovely. We love that. We
They don't
love it.
hire, man. A father never stops protecting the kids, right?
So have you had any genetic tests as well as the PSMA test, PSMA scan?
I gave some blood just the other day at that experimental place. They're starting
Mm,
a process there, but I can drop or they can drop me whatever when they want. But they said that they're gonna go to do get that thing done from the biopsy. They want to get the what they do to check for genetics things.
mm,
Everything just hits during the holidays and everything's
yeah,
open one day, close the
yeah,
next. You know what I mean?
yeah, yeah, yeah,
And the problem, I know over there to get over there to traffic and all.
yeah, yeah. Rick, am I missing any more questions?
I don't think so, although we don't know. Well, yes, a couple of little things. Do we have your email address? Because if we don't, we should get it so we can send you reminders before every meeting.
Okay.
You can put it in the chat window, or your daughter can put it in the chat window for you, which is the two little boxes at the top, and you can send it. If you don't want it to go to everybody, then you can send it to just me, and I'll make sure you get into the chat window. And the other question, Ben, is
Okay.
Yeah. So,
yes. Go ahead.
well, I guess like we also had just a couple questions too to get like y'all's input because, like the
Well,
urologist.
Yeah.
hold on a second. We'll
Oh,
get there. We'll get to your questions
okay.
as well. The other question is, where are you being treated? Where is this Dr. De La Certa?
The urologist cancer center, I believe.
Cancer center. Yeah.
It's on Petersburg Road and
San,
Okay.
Floyd Curl Circle or something like that.
yeah, San
Okay.
Antonio Cancer Center.
San Antonio Cancer Center. But that is not, doesn't have anything to do with UTSA, or does it?
No. Mm-mm.
Okay. So that's really what we wanted to know. And you're pretty sure that this guy is a urologist?
Yeah, he took over Dr. O'Neill I first started with back in 2018, I think.
Okay, that's that's I think what we and the Gleason 9. Do you know if that's a 4+5 or a 5+4?
I have no idea.
I don't know.
They gave me a bunch of papers, but
Let's see. I think we have it here.
he's got
Yeah.
some looking.
It's a 4+5.
Okay, that's good. All right, 4+5. See, that's why we love having your daughter here, because she's like she's ready.
Just say it. Smarter people around you.
That's right. Oh, and I have one other question. Are you a vet, Dave? Are you a
Yeah,
vet?
72 to 75 in the Army. Yes.
Okay, so we'll get involved with that when you give me your email. We'll get you into the veterans group as well, and it may be that we even want to get you treated through the VA, because we may have better access to the doctors that you need rather than the community doctors.
Yeah.
So are you registered with the VA right now or not?
No, I mean, I'm a veteran. My driver's license says I'm a veteran. I got a
Okay.
good DD 214.
We believe
But
you.
I have no dealing with them.
Okay, well, we'll help you with that, because we've got experts who are actually on this call, and we have other calls for veterans, and we'll get you into the veterans group, because there's a lot that you're entitled to, including money, because you're a veteran. So we'll help you with all of that. But it also gives us another outlet or opportunity for second opinions or for primary treatment, and we'll address that momentarily. But let's, Ben, I'm handing it back to you either
Yeah.
for Dave's questions or for anybody else that wants to.
Yes. Why don't you ask your questions?
You mean our questions?
Yes, ma'am.
Okay. Well, I guess like the first question is, well, we got this diagnosis and then we had that PSMA PET scan. And then is there other scans that one should do like outside of the biopsy and outside of that? Because as part of this clinical, he's also it looks like they've kind of signed him up to do like a bone scan and then also a MUGA scan. And but those are not being ordered until like sometime in February. And so I don't know if it's like better, like, or what are those tests? Like, are those good to have today? Or is the gold standard the PET scan already?
Yeah, the PSMA PET is in fact the gold standard. A bone scan is sort of superfluous. It's less sensitive than the PSMA. Will not pick up anything extra. You may need it for insurance purposes for some kind of approvals, but you certainly don't need it diagnostically. And the MUGA scan, that's MUGA.
Yeah.
Has anyone heard of that?
No. I know. I'd like to just make a comment on the
Hmm.
bone scan before we talk about this MUGA scan. And probably there's a bunch of people Googling that right now to try and figure out what that MUGA scan is. But it isn't exactly correct that it isn't useful,
Hmm.
because there are situations where if you don't produce PSMA, that scan can be very helpful.
Hmm.
But it sounds like you produce PSMA because there was a result on that PSMA scan. Isn't that right? That you did see some lesions on the PSMA scan? Did Dave, did they see lesions on the PSMA scan?
Lesions, I mean, they saw like they called it activity
Yeah.
of AVIDIDY, like
Yes.
throughout the lymph nodes.
Yeah.
Yeah.
So the PSMA was avid throughout the lymph nodes, but not everybody produces PSMA, and not everybody produces PSMA everywhere. But in your case, it sounds like Ben is exactly right, and the bone scan isn't going to add too much. So let me. So
I think the
what
one
was
that
your?
I think that go ahead.
Let me ask your daughter one other thing. This trial that they want to put your dad in, do you have the papers on that?
Not yet. Not yet. Yeah, we don't have the all the papers on it. Like all they've done so far is um like they did a blood test to see if we even like if he qualifies to be in it because
Mhm.
I think it's like a genetic type of thing to
Okay.
see if you can be in it or not. Or I don't know, I guess that's why they're doing it. But they said once they kind of know some of the blood work, then we'll either be in or out of it.
Did they
But I
give
mean,
you
even oh, go ahead.
did they give you a number? Did they give you a number that was like it would have started with N as in Nelson, C as in Charlie, T as in Tom, an NCT number?
Um, no, I don't think so, not yet. Um,
No.
but but
No.
I think like what they told us was that this would be the best treatment, would be the clinical, because it had spread to the lymph nodes and you can't do surgery or radiation might be too much. I mean, maybe that's what we heard, or, everything obviously like kind of hits you kind of hard once they're telling you this. So,
Sure.
we did like order, we are going through like some like second opinions, and they asked us for the doctor notes, and we don't have any doctor notes. Obviously, we have like the scans, but not the doctor notes. And so I'm not sure if in there it would kind of talk a little bit more about the treatment plan.
Well, one thing you can do in your preparation, and we'd suggest you do this, is write to Dr. de la Cerda through the portal and ask him for the NCT number of the trial.
Mm-hmm.
And then we can help you understand what that trial is about. There are a couple of issues, I think, that the group is concerned about. Frankly, your father should not be treated by a urologist at this point in time. It's beyond the scope of a urologist's knowledge. And he needs a medical oncologist, and specifically, he needs a medical oncologist who is experienced in prostate cancer, and we call that a genitourinary medical oncologist. They also may have expertise in bladder or testicular or other areas down there in the nether regions, but we want to get him to a GU medical oncologist. Now, it's possible San Antonio Cancer Center has a GU medical oncologist. If they do, your father should be, or you should be advocating for him to see them right now. Our other concern is that if they're running a trial, they may want to fill that trial. It sounds to me like they do want to fill the trial because they don't even know if your dad's qualified yet, and they're already trying to get him interested in a trial. And that's kind of putting the cart before the horse, is a way that I would put it. Now, there are GU medical oncologists at UTSA. I need to look up, but I do know there are a couple that are there. I'll look them up in a minute. We know that we can get your dad to that GU medical oncologist or those GU medical oncologists through the VA. And I'm going to let Captain Jim talk about that momentarily. At the same time, it's possible that what San Antonio Cancer Center wants to do is the right thing. But a lot of times, as in your case, they push you into it. Fortunately, Dave, you got a smart daughter. What's your name? We can't keep calling you daughter. Sorry?
Jessica?
Jessica, okay. So Jessica's on top of all of this with you, and we're going to make sure you get the right treatment. Have you started any medicines yet?
Yes.
What medicines have you started?
It starts with an O something. Let me go get the
Orgovyx?
case.
Orgovyx?
It's right here.
Oh, it's
it-
O. Oh, tell it, Jessica.
Orgovyx.
OROY. Yeah.
Orgovyx.
125 milligrams.
Right. So he started you on Orgovyx. Okay. And anything else?
No, I think I stopped taking the other two that he had prescribed all through the years.
Okay.
Tamoxifen
Yeah.
and finasteride.
And finasteride. Okay. So that sounds like you have an enlarged prostate. You've had that for a long time, and that you've had trouble peeing, and the tamsulosin is to help you with that. But the Orgovyx is for the cancer, and frankly, there should be a second drug that is prescribed with that. And my guess is he's holding off on that second drug because of the trial. Because if he gives you that second drug right now, you may not be eligible for the trial.
Could be.
How long have you been taking the Orgovyx?
Saturday?
Okay. So we'll talk to you a little bit about that right now too, because at some point fairly soon you're going to feel the impact of the Orgovyx. It's too early yet. 2 or 3 days is a bit early, but within a week to 10 days you will start feeling the impact of the Orgovyx. Is there anybody on the call who started Orgovyx? Their first treatment was Orgovyx, and Joe, and how long, Joe, was it before you felt the impact of the Orgovyx?
You know, I hate to say it, but I have basically not really felt it. It's been about a
Great,
month and a half.
fantastic.
So
Did they, Dave, did they measure your testosterone before you started the pills?
I believe not.
Yeah, that's a problem because it's good to know what your baseline testosterone is. You may want to get a reading tomorrow morning, first thing, call them up, tell them you want it right away, because it's possible that it's going to be somewhat contaminated by the 3 days, but we may get some sort of a reading. But again, we always recommend that they measure your testosterone before they start you on medication. Anyone else start off on Orgovyx here today? Okay.
I've never been on it, but I have a feeling that the Orgovyx is going to act very rapidly.
Yep. Thanks, Dr. John. So,
Next is that going to happen?
sorry, say that again, Dave.
What's going to happen to me? The effects.
Well, you'll go around you'll want to go out and buy a pink handbag, and you'll want to be walking up. No, listen, most of the guys in this group, if not every one of them, is on that type of treatment or has been on that type of treatment. And we can help you manage the treatment and we can help you manage the side effects. Who would like to answer Dave's question, because it's a very valid and important question about what's going to happen to him?
I could take a shot at it. Dave, I was on a very similar drug. You might not feel as vigorous as you used to. You might feel a little less strong, a little less sexual if you do have those feelings. You might feel hot flashes where suddenly you start sweating and think that it's very, very hot and you want to cool yourself off. These could be rare or they could be frequent. So those are the main things that I would look out for at this early stage. Jeff, you were going to say something. Do you have something to add to?
Well, the muscle deterioration, you're going to want to exercise regularly, try to do weightlifting if you can. You're going to get your belly, you're going to get a bigger beer belly if you have one, or even if you don't. So you want to try to do sit-ups to exercise to keep your muscles tight. The hot flashes may take a while to come to you. They took 4 months before they came to me on Orgovyx. But you really need to exercise because there's a lot of fatigue for some people, not everybody. If you start having fatigue, realize that you've got to exercise, you've got to walk, and maybe go to the gym or do equivalents. That's enough.
Yeah, it's the thing you least want to do, and it's the thing you most need to do is to get exercise when you're feeling fatigued. So, Jessica, do you have any information about the trial, like the name of the trial, or the drug or the treatment they're investigating?
I had tried to Google it when they were talking about it, and I don't have the number, but what I kind of understood, like when the doctor was explaining it, it made it seem like it was a bit of like as a substitution of chemo, so that an inhibitor of some sort, maybe. Um, and but again, like I don't know, like how do you make the determination of like, is this clinical, which is obviously not yet fully approved, a better like
I can,
what the doctor told my dad was that it spread to the lymph nodes, so surgery is not an option. He said that that radiation, it's like everywhere, so it'd be very difficult to kind of get it, and it would be very painful and just like etc. So like we're obviously going to go for a second opinion, but like everything that we Google kind of like shows that that's maybe not 100% accurate, you know, and I guess these are all judgments and they're making calls too based on their experience. But um yeah, I don't know if anybody has experience with like what you go to these like second opinions, and like what should we be asking in the second opinion? Just show them all our records and then let them kind of decide how they would treat it, and then we have to hold, you know, kind of compare their decision against like a clinical trial, which may or may not happen. You could be taking a sugar pill, you may not be taking a sugar pill. Like those are, I mean, it's just hard to kind of make those calls.
I think the important thing about deciding on a clinical trial is to make sure that the very least treatment you get is up to the current standard of care for what you've got. If the people taking the sugar pill are also getting completely up-to-date standard of care, which in this case would probably be 2 or 3 medications taken together, then the addition of the active drug or the sugar pill is not going to do you any harm. If you have side effects, you can always stop. But if it's instead of standard of care, when you said the word substitute, it bothered me a little bit. If the experimental drug is instead of standard of care, we might find ourselves discouraging you from getting involved because we want to make sure you get at least the best possible care you can get for what is wrong. So we do need to read about this trial once you find out the number and name of it.
Jessica, does the name PARP inhibitor ring a bell? Were they talking about PARP inhibitors?
I think that's
'Cause,
what it was about, maybe. I know they said the word inhibitor um in some of the discussions, but
I mean,
like I said,
that would tie in with the blood test, and it might
Yeah,
not be that they're giving him an experimental drug. It might be that the trial is to see whether giving PARP inhibitors this early in the disease is a good idea.
Mhm. Mhm.
hmm
I have a couple of questions, and we have a couple of people with their hands up too. So
Mm, mm,
or they did have their hands up. They may
huh.
have taken them down. I know Joe Commander had his hand up, and I think
I've taken it down. I don't need to.
okay, and I know Jeff has his hand up again, but I thought there was somebody else.
Luther was the other one. Luther.
Oh, Luther, yeah, Luther had his hand up too. So let me just say this, and then we'll go to Luther. First of all, at age 72, we don't give medical advice, but there are very few 72-year-olds who attend this group who would opt for surgery. It's a very difficult, it's a complicated, long, arduous surgery. And there are many practitioners who don't think that at 72 surgery is the right way to go. That's the first thing. The second thing is that your dad is a good candidate for radiation, and whatever happens, at some point, they should consider radiating the prostate. Now, there are practitioners who aren't up to speed with that. But if you went to a center of excellence, the likelihood is they talk to you about radiating the prostate at some stage of the treatment. It might not be in the first 6 months, but it might be in the second 6 months, or in before 18 months. But the doctor should not be telling you that you're not a candidate for radiation, because that's not the case. We know now that radiating the prostate can help. Now, that again may not fit in with the trial eligibility. We don't know until we see it. I have a couple of questions for you. What type of cancer is in your family, Dave? You've had a throat cancer, you mentioned that. What other cancers have either your siblings, your parents, your children, your nieces and nephews? What other cancers are there in your family? So we're not hearing you. Say that again.
Breast cancer?
Breast cancer, did you say?
Yes, my niece. My brother had lung cancer. They both passed away.
Okay, so you lost a niece to breast cancer, and you lost a brother to lung cancer, correct?
Yes. And I'm
And
not sure what kind of disease my dad had, but he passed away too. But he had it was something internal, like a maybe prostate cancer. I'm not sure what it was. They never told us.
mhm,
My parents,
mhm.
my mother.
Um, Jessica, do you know if your cousin had any mutations? Did they test her? Do you know if she carried BRCA or something like that?
We don't know if she did, but whatever kind of cancer she had, I mean, she caught it, and she was going through a lot of testing, but they said it was a very, very aggressive breast cancer. And so
Right,
she passed away at like in her 30s.
right, right,
Um,
right,
so
right.
she was, yeah, she was pretty young. And then I know I've tested myself for
Yes,
genetic cancer, and I know I don't have any like
Marcus.
genetic markers. Yeah.
Okay.
Not
Well,
just the BRCA ones, but like more of an expanded test through forget the company name, but they test like 20 or 30, not just the BRCA ones.
right. Color, probably
Yeah,
color.
yeah. I
Um,
think it was Tempest. I feel like it was
oh no,
Tempest.
it could have been a Tempest test. That's, yeah,
Yeah.
which is a better test than a much better test than the color test. I mean, I just was working with somebody this morning who had a color test several years ago, and it turns out that they have a bunch more mutations that color didn't cover, and they're probably inherited mutations. But so color is good, but it's better than nothing, but it's not the greatest. Um, I mean, my guess is with that history, they might be looking for a couple of mutations to see if you're eligible. But I think that Ben's assumption that it could be that they're looking at a PARP inhibitor for you. Um, if they were, I would tell you not to even bother. If it were me, I wouldn't even bother with the trial. I don't like early use of PARP inhibitors unless you have certain mutations, and even then, I mean, we've got a young guy who's 50 right now who's doing a PARP inhibitor before he has surgery, and I'm even concerned about that. And the reason is because these PARP inhibitors are very toxic, and you can have adverse reactions to them, and the doctors don't seem to appreciate that. The doctors that do appreciate it aren't heard loud enough. But I'm watching the time. Jeff Marchi, you have a question, and then we should probably. Oh, and Luther, you go first, and Jeff Marchi, and then Jim Marshall, and then we need to move on to the other new guy.
Okay.
Luther, go first.
Sure. I just gut reaction from someone who has no medical training but just finished his radiation. Dave, I feel like your questions should be around doublet versus triplet therapy and what are those options? What's the right option for you with the conventional treatment, with the medical oncologist and a radiation oncologist? You just got diagnosed a week ago, and all the focus is on a clinical trial very, very quickly. It just seems I'd be looking at, is doublet therapy right for me or triplet therapy if it was me?
Very good comment. And we need to explain what doublet and triplet is. Doublet is something like Orgovyx plus another pill that blocks the androgen receptors. And that is probably the standard of care for you because you don't have that many. We don't. Well, how many lymph nodes lit up? Do we know in the PSMA how many places did they see this avidity?
I saw the screen. I think it was about 6. No, about 6.
Okay.
Yeah.
Were they all pelvic lymph nodes? Were they all
No,
over the body?
it was like the neck, the chest, the abdominal, and then pelvic.
Okay.
Yeah.
So you may be a candidate with 6 for also adding chemotherapy, and that's called triplet. So doublet is 2 pills basically, or maybe 3 pills depending on which medicine they choose. And triplet means that they add chemotherapy. And Luther's exactly right. The second opinion, that's what you should be talking about. We shouldn't be talking about trials so early in the day. I agree. Jeff Marchi.
Yeah, it was mentioned earlier that they said instead of doing chemo, he would do this inhibitor, which we think is PARP inhibitor. And the thing, this is a perfect case for triplet therapy. This guy has it all over his body. You can't give him 2 drugs that'll do it. Chemo is the only way to go. It's and they're trying to avoid it by going to a PARP inhibitor. It sounds like. I mean, they talk about the fact that triplet therapy should be used more often for people who have multiple sites of cancer. So that's definitely what they should be, talking to the doctor about whether or not chemo really does make sense for him.
Yeah. So we can help you with all of this, but I want to close out for you with Jim Marshall. Jim, you want to talk? I know.
Pluvicto is another thing, by the way. They want to
not right
chemo.
now. Not right now, Jeff. Okay, they're not appropriate.
Ooh.
Right now. The reason is because I know that the San Antonio VA is a very good VA. We have somebody who moderates in another one of our groups who does a bunch of work there. And I really think that we should be getting you into that VA system, but I don't know how long it's going to take to get you into the system. So I want to go to Captain Jim because he leads our veterans group.
Dave, are you a veteran? I take it you are?
Yes.
You are a veteran. Are you Vietnam era?
72 to 75, but I didn't go to Vietnam era. Yes.
Okay. Are you Army, Navy, Air Force?
Army.
Army. Okay. Okay. I need to get your information and I can talk to you offline. Now, are you currently enrolled within VA healthcare?
No, sir.
You're not. Okay. We can probably get you in quicker. And I think I know how. Okay. So, I need to get your contact information or else I will send you mine. Okay. Do you know how to look at the chat? Okay, the
Look
chat
over
is
here.
the 2 squares up there.
Yeah.
Okay,
Oh,
if
okay.
you click on that, okay, I will send you my phone number and email address, okay?
Okay.
And you can actually send yours to me or a phone number, okay? And I will reach out to you after this, okay?
And
Yes,
Jessica, send your dad's email address to me as well.
yes.
And I'll get you registered for the vets meeting, for the vets group meeting. The next vets group meeting is going to be next week, right? Right, Jim?
Next next Tuesday.
Tuesday. Yeah.
Yes.
And we'll give you a lot of help. We've got everybody from privates to generals in that group, and they're very knowledgeable. And we have um, we have people attending that group who spent their life working at the VA, like Dr. John here, who's in this group right now, who was a doctor in the VA system most of his working career. And we don't see Sylvester today, but Sylvester was a social worker for 39 years at the VA. So we know the ins and outs of the VA, and we know how to get treatment for you. And I'm going to look and see if there is. I'm pretty certain there's a doc, and I'll put it in the chat window for you. And
Okay, great.
Tony Fig makes a really good point. These groups, as we said, are recorded, and the recording will probably get posted Wednesday or Thursday, depending on Mr. Nathanson's availability. But you can listen to all this again on the recording. So if you think you missed something, it's recorded. But please send us that email address so we know how to reach you. And Dave, if you don't use email, Jessica, put your email address in. That's perfectly fine. Okay. We got to move on. I'm
Yeah.
sorry because we have another new gent.
Yes. Yes. Come back next week where you certainly want to know more.
Right. Next
Ethan?
week, the meeting next week will be on Monday. Actually, yes, the meeting next week is next Monday, the 6th. And Tuesday is the veterans meeting.
Thank you. Ethan Boger, you are next. Actually, and I get to ask you the same set of questions. Where do you live, Ethan?
Well, right now, hello there. Right now, I'm living in Israel, and it's right
Ooh.
now around 2 in the morning.
Oh
Here.
my gosh. Welcome.
Thank you.
Welcome.
But for many, many, many years, I lived in Cincinnati, Ohio. That's where I was diagnosed. There was a really great support group there that I want to give a shout out to, the Cincinnati Prostate Cancer Information Group. They were wonderful folks, really helped me out.
But you're getting your treatment in Israel. You're living there permanently now.
Yes, I've been here for a few years now. Yes.
Yeah. Where are you? What town are you in?
A little town called Nesher, which is near Haifa, which
Okay.
is the northern part of the country.
Yeah. I have a very good buddy in Binyamina.
That's a very nice place.
Yes.
Ethan, how old were you when you were diagnosed?
I'm 76 now. I was diagnosed exactly 10 years ago, December 2014. Yeah. I had an MRI and a biopsy, and it was a confirmed Gleason 4+4.
Mm-hmm. And what brings us to you now?
Why am I here today?
Yes, sir.
Yeah. Well, That was 10 years ago. I sort of obfuscated for a while. Then I had FLA, focal laser ablation, which I shouldn't have had probably. That lasted for a few years. Finally, the cancer came back, and I went for traditional radiation plus ADT. I had brachytherapy up in UCSF. Dr. Sue, that was HDR brachytherapy. Then I had 25 rounds of proton therapy to the prostate and the nodes, the near nodes. Yeah, and so then
Where was the proton? Because they don't do that at UCSF.
No, I had it back in Cincinnati. There's a new
Okay.
proton center there. Yeah.
Okay, I know, and I know Dr. Shu, so yes. So, okay.
Yeah. So I was in ADT for almost 18 months. And then that was in 2021 when that ended. And then a year later, my PSA dropped to zero. I mean, my testosterone went to zero and my PSA went to zero with the ADT. About 2 years ago, about a year after the end of ADT, my PSA started to creep up. And it started to creep up pretty rapidly. Doubling time was around 7 months. Then the doubling time went down to 4 months and 3 months. And before I knew it, my PSA was about 1, something like that. And then I had to fight here. This is, public medicine. They're very reluctant to treat. I want to get a PSMA PET scan, and I had to fight for it. I finally got one. By that time, my PSA was about 2. And they discovered a bone spot in the left femur neck, quite a large spot. Yeah. Trouble is, though, that the uptake was very low. The uptake was well below liver. And so there was a lot of concern here that maybe this was a false positive, or I don't know what they wanted to get me to get an MRI to confirm. But around here, by the time it would have taken months and months to get MRI. So I eventually went to NIH. I thought I'd go and get into a clinical trial, and then they say an orthopedic oncologist there just by doing some X-rays confirmed that it really was a tumor. And so anyway, but bottom line is, 3 months passed, and I got another PSMA PET scan, and it already showed 20 tumors, and my PSA had risen to about 10.
How quickly did this happen, did you say?
Right. In September of last year, I had a PSMA PET scan when my PSA was around 2. Nothing was done because of all this obfuscation until December. In December, 3 months after the first PET scan, I had another PET scan. By that time, they identified 20 bone lesions.
Okay.
Yeah.
So
and that's when I started.
What did they recommend when they saw those 20 lesions, Ethan?
Yeah. Well, they said I need to get the so-called triplet therapy. I had, ADT plus Abby, and then 3 months later I had docetaxel.
Okay. 6 sessions?
Yes, sir.
And which hospital were you
Well,
at?
in Haifa, there's a good hospital, a teaching hospital called Rambam, Rambam.
Right. Okay. And I'm assuming this was under the supervision of a genitourinary medical oncologist.
Yes, there's a very well-known oncologist there. Her name is Pe'er, P-E-'er. ER. And she's basically the head of the department there.
Okay. I think I've seen her name on papers and stuff.
Yeah, they're involved in clinical trials. There was a recent one called Capitilo.
Yeah.
I had a foundation one, somatic genetic test, and it showed both PTEN and P53 loss, which is why they decided to give me triplet therapy.
Yep.
Yeah.
Yeah, you were one short of the trifecta.
Oh, really?
RB1 is the...
Oh, yeah, the bad guy, yes.
Well, P10 and TP53 aren't a heck of a lot better, although there's a bunch of guys in this room right now who have PT and P10 and TP53. The big concern with P10 and TP53 is that should you need or should you choose to look at Pluvicto, you're already behind the eight ball, because we know that P10 and TP53 tend to make success with Pluvicto or a PSMA radionuclide more removed. Now, there are other mutations that favor it, as it so happens, but like ATM, but you didn't have that. You pulled P10 and TP53. Anything else? Do you remember from that?
From the foundation one?
Yeah, from Foundation Medicine.
Yes, I have an inherited mutation, PMS2, a Lynch syndrome mutation.
Oh, yes.
Oh.
Okay.
Yeah. I've had two other cancers.
What have you had?
I had a bladder cancer about 35 years ago.
Yeah.
And I had a colon cancer also about 2 years ago. I had 8 inches.
Yeah. Don't feel don't feel that you're on your own. That this lady that I work with in Romania, I lived in Romania for a while, and the lady that I'm working with in Romania, she's on her third cancer, and she's also a Lynch person with MLH1. Were you MSI high?
No.
And your tumor burden wasn't that high?
No.
No, okay. But you need to keep a good eye on that, because with PMS2, that could change. So that could always change. But has Dr. Paer talked to you about all the things you should be doing with Lynch, all the other cancers you should be regularly checking?
Well, they have a Lynch syndrome clinic over there.
Oh, wow, great.
And I'm part of that program, and I'm getting a colonoscopy every year.
Okay.
Isn't a lot of fun, but that's the surveillance.
That's the surveillance, but you got to do that. But there are other, as you know, with Lynch, there are other cancers. There are other cancers too. Are they doing? Because this is something we've been discussing. Are they doing a full body scan every year?
Well, I'm getting a PSMA PET scan every 6 months or so.
Yeah.
But you mean like a full body MRI or?
Yes, full body MRI. Because the reason why I ask is because there's a lot of doctors now, and even some of our GU medoncs, like that. You see Joe Blanchett down in the bottom of your screen?
Yes.
And you see that lovely blonde behind him over his shoulder?
Yes, of course.
Well, she likes full body scans.
Mm-hmm.
And if you were being treated by Dr. E, the likelihood is with Lynch syndrome, she'd be doing a full body scan every year, because we're looking out constantly for where a new cancer might arise. This is something I'm talking about with my friend Carmen in Bucharest. And it's something I would explore with somebody like Dr. Paer, or with your Lynch syndrome clinic.
Well, how about an FDG PET scan?
Yes, an FDG PET is probably, I cannot compare a full body MRI to an FDG PET. I don't know. Is anybody in here feel capable of doing that? Dr. Jeff or Dr. John? I mean, how would you compare a full body MRI to a FDG PET?
I think a PSMA scan will beat an MRI. I do not know about an FDG PET scan compared to an MRI. They're pretty different tests. One is testing function, one is testing structure, but I don't know which is better for surveilling for cancers.
Right. I mean, we're not really concerned with PSMA here because what we're looking for is other cancers that might arise. And I think it's a really good discussion that you should be having, Atan, with your with the Lynch people, and saying, what do you think? FDG PET versus full body MRI, and I'd love to hear.
I know that getting an MRI is very difficult. I mean, I don't think anybody here offers a full body MRI scan. For sure, it's not covered by public health. Israel has a very good public health system, but it's limited. It took me 4 months to get. I did get an MRI of the pelvic region, but it took 4 months to get it. A full body. I mean, it's time in the machine, right? And it's, I'm sure it's very, very difficult to do here. But I could go back to the States. I do have Medicare.
So some docs, if you came back to the States, we may well send you to Dr. E, because she seems to be able to get a full body MRI through Medicare. Is that right, General?
Yes, that's correct. I've already had 2, and she's giving me a 3rd one this coming March, and Medicare pays for it all.
And the thing is, Etan, that not all the docs, we could send you to another doc, even one we like, and they'll tell you, no, we can't get it. But we know she can get it because she does it, right? And I also can guarantee that Dr. E would recommend, because you carry Lynch, she would want you to have that. So she's in Houston. We should tell you where she is. That would help, right? She's in Houston. At Houston Methodist. She used to be at MD Anderson for 14 years, and she moved over to Houston Methodist.
I'd be grateful for her contact information. Thank you. Sure.
And we would be grateful for yours. Do we have yours?
I believe you do. I did sign into AnCan, but I can post it to the chat if that would be helpful.
I will look, and we will momentarily. I will put Dr. Her full name is Eleni, Dr. Eleni Efstathiou.
Oh, Efstathiou. There's an
She's not related to the radiologist, Jason.
Okay, gotcha.
She's not related to the radonc. But yes, there is a radonc. She knows him, but they're not related.
I understand.
And we love her, but we call her Dr. E for obvious reasons.
Okay, and she's at Houston
Methodist. Methodist. Yeah, they treat you. Don't worry, they treat Jews there too. We've checked. But we really like her. I mean, but you'll come back. We'll work with you. But I'd like to know. Let me post that for you. So,
thank you.
What are your specific questions for us?
Sure. My first question really is related to that delay in treatment. when I was first when I did the first PET scan, my PSA was 2, and they only discovered 1 bone lesion, and then 3 months later there were 20. If I had started treatment, would that have made a big difference? I mean, that's been bothering me ever
Right.
since.
So can I answer that? Can I answer that in my own fashion?
Sure.
If my grandmother had had balls, she'd have been my grandfather.
Yeah.
You know, we don't know. Should you have been treated earlier? Would it have made a difference? I mean, yes. How should they have treated you? I mean, did they start you on the abiraterone when they just saw the femur?
No, I didn't get any treatment until the end of December.
No, yeah, I mean, yeah, they should have put you on the abiraterone right away with Orgovyx or whatever else they gave you with it, or Lupron or whatever they gave you with it. But yeah, they should have done. Can we say how? But the problem is, nobody knows how advanced the cancer was at that first point. It might have been like just on the verge, but it didn't make enough PSMA to show up. But then 3 months later, it didn't. It could have been in all the spots. So nobody will know. I mean, if you see Dr. E, you can ask her that question, and the likelihood is she'll probably answer it in a similar fashion. If
Yes.
if
Yes.
This is John. Just a little comment about that. We don't want you to go through the rest of your life regretting those few months, because that just eats away at you. If you look back at it from the doctor's point of view, back in September, you were not even metastatic. From even that femur lesion being less than background liver avidity, you really could not be considered at that point metastatic. So I do not think anybody would have treated you with chemotherapy back then.
Yeah. Well, that's my other question. My PSA never rose above 5, and you know, and then the fact that my all of these lesions are not they don't absorb a lot of PSMA,
right,
which worries me to some degree.
right.
That
So we have another gentleman like you, except he's lost his voice, so he can't say anything. Mark Valens, who has a lot of lesions right now.
yeah,
But he's never made more than higher than 8, I think it is. I don't know. I'd have to go look. We can't ask him. One. Oh, 18. I don't know. But he has it's never gone very high. And that, to be honest, is a function of the P10, the TP53, and the PMS2. And we're always very concerned when we see men with low PSA and Gleason's of 4+4 and 4+5 and 5+4, because it signifies weird disease.
yeah,
You know,
that's my biggest concern. I'm not sure how long the abiraterone will be effective. What will it do afterwards? I think
yes.
that it seems like Pluvicto or some other PSMA-based treatments are not for me. That's part of my concern.
So I think Dr. E would be a good fit for you. I'm
Really,
not saying anything about Dr. Pear, but I think that Dr. E would be a great fit for you.
really. Okay.
Um, and I do think probably sooner rather than later.
Yeah.
So if you got any other reason to come over, try and build in and as soon as you decide, we'll give her you'll get in touch with them, but we'll give her a heads up that you're on your way.
Okay,
And Baruch Hashem, she'll come up with a great treatment for you.
that would be terrific.
Oh, Joel Blanchett also has. Do you see that in the chat window? Joel, speak up about your P10 and your TP53.
Yeah.
Yeah,
How are you doing?
I've known about it the last 6-7 years now. The first thing my GU medical oncologist did at Johns Hopkins, Dr. Antonarakis, 5 minutes after he first saw me, he ordered a Foundation One medicine, and that's what found my P10 and TP53 that I've been monitoring ever since. So Dr. E is totally aware of that. She gives me a Tempest test every year, and she is. That's why she even took. I was on a drug holiday for 28 days. She even took me off the drug holiday and put me back on darolutamide until she figures out what my next whole body MRI tells her.
Okay, I'm sorry. What kind of test do you get yearly, did you say?
Whole body MRI.
Oh, that's what you meant? Okay.
Yeah.
Wow. Okay.
It's 2.5 hours in the tube.
Oh my God. I do have a pacemaker, which is one of the reasons it took such a long time to get an MRI in Israel. No hospital wanted to do it because of that. So that's another complication. But I'm sure I should have that conversation with her.
Yeah, as far as I know, they ask me that question every time. They ask you about a series of 70, 80 questions before you go in the machine. But I don't think that's a concern. I may be wrong about that because I don't have a pacemaker, but they want to know about it, but I don't think it'll stop you from getting the scan.
Okay, great. Thank you. All righty.
Yeah, so I think this is a good shidduch, Etan.
All right, terrific.
A good match for those who don't understand that. We know you'll like her. There are a number of guys in this room who see her.
Okay.
We tend to refer to her if we can, but I think she also has the right sensitivity, and she understands the implications of P10 and TP53 and this issue with the lynch.
Yeah.
I'm actually trying to figure out right now if any prophylactic treatment is recommended with lynch, because people like you suffer with repeated cancers, and a lot of times they don't want to do treatments that might be appropriate unless they see metastasis. In the case of my friend, she's had 3 cancers, but they've all been localized, significant but localized. You have a different situation. What is good in your situation is that whilst PSMA may not be treatment may not be right, you may be a good candidate for an immuno-oncology drug.
Yeah. Yes, I've been looking into that. My PMS2 is heterogeneous, so only one allele is affected.
Yeah.
So I'm not there are clinical trials. Actually, there was a really good one that was published recently, which showed incredible effectiveness for people who were truly MMRD, which I've been told means that both alleles are affected.
Right.
So they truly lost all PMS2 protein. And in that trial, it was incredible. I think it was a phase 2, but almost everybody with MMRD had a remarkable
Bonded. Yeah.
response.
We got to, Ben's reminding me, he's absolutely right. We got to move on. We got 7 guys who need time. Ethan, you are signed up. I will check and see if there's anything more you need to be signed up for. I put Dr. E's information in the chat window, so just click on that. It'll open in your browser. And it was probably worth your while staying up for us. So,
Sure.
you know, come on back. I'm just thrilled to have somebody from Eretz. I think this is a first, and we've been going a long time, so it's a real thrill. It's a real thrill for me.
All right, thank you. I'm very grateful for this group, by the way. You've done great work, and keep it up.
Thank you, Ben.
So, Kang, you have been waiting a long time. It's your turn.
Thank you, Ben. Okay, I did 2 PSMA PET CT. One is in July, one is in October, and nothing was showing actionable. And I did FDG today. I have a question. What is the FDG can provide information-wise that the PSMA PET CT cannot? In my case.
So the concern and the reason we pushed you to get the FDG is because, as you heard us say before, not everybody makes PSMA. So the fact that we don't see PSMA lesions, and you've had 2 already, and your PSA is now on recurrence up around, where are you, 5?
5.5.
5, right? 5 point something, makes us suspicious that you could be one of these guys who doesn't make PSMA. So we have to do a different type of test. And the test that we're suggesting that you do is the FDG PET, because that infuses glucose, and cancer loves sugar. And when they put that sugar into your body, it sparks the cancer, and it gets all active. And then we can see if it shows up on this FDG PET. So essentially what we're doing is we're looking for cancer and for lesions that might have been there on PSMA, but if you don't express PSMA, we'd never see them. Am I making sense?
Yeah. I guess diagnostically wise, I remember Rick mentioned with FDG, it's good enough to decide that chemo could be the right treatment. I don't quite understand. Like, what if FDG doesn't show anything at all? I'm
Okay,
just wondering if possible.
Right. So there's something going on, but we can't figure out what it is. Right? Dr. Tsao at Mount Sinai is saying, well, chemo's a good place to start. And he wants to put you into this trial, which involves a bispecific T-cell engager. A bispecific T-cell engager, which may make it more effective. It may make it less effective. But the thing is that what we might need to do first, if we see a bunch of lesions on the FDG PET, is to test those lesions and to see if those lesions are changing, if they're morphing, if they are expressing a different type of prostate cancer.
A biopsy with those lesions?
Yes, they would. The best way to do it would be to biopsy. Well, there's a couple of things there. It could be a biopsy, but it could also be some testing for some of those things that we mentioned before, like somatostatin and chromogranin A. And if there was a response, then it might be a better to treat you with a different type of chemo, and forget that trial right now. And that's what we're trying to figure out. And Dr. Tsao has not even considered an FDG PET.
I realize that.
And that's a great concern to us, because he's willing to treat you with docetaxel, and he doesn't even know if you have lesions. Now, there's another thing too. If you're a guy that produces a bunch of PSA, and if this is all coming from one or two places, we might just try doing spot radiation. You need to discuss with him or with Dr. McHugh. What about some spot radiation first? Let's see how we respond. If the FDG PET showed one spot or two spots, it would be a different response to if it showed 10 spots. But we don't know where the cancer is. This is why I find it amazing that Dr. Tsao didn't even do the FDG PET. Both Len and I were dismayed. So that's why I'm saying to you, before you commit to doing trials or chemo, we need to see the result of the FDG PET, and we need to see what the updated NGS says.
Yeah. He did mention the spot radiation back maybe when in July, when the first PSMA was done, and nothing was showing. And the second was done, nothing was showing. So I guess he gave up that idea.
But what if you don't produce? But why did he give up the idea? What if the 20% of men don't produce PSMA?
So with today's FDG, new information could help to for the problem. Yes. All right. Yeah. Thanks. I guess that's it for today. Thank you.
Thank you, Kang.
Unless.
I'm sorry, unless
other gentlemen have ideas, similar experiences. That I guess it's tough to make a decision. It seems like doctors like to push a patient into clinical trial, right?
Yes.
Paul was like that, and when I do the second opinion with Dr. McHugh, I since he preferred to get the clinical trial early. I have that impression also. I actually mentioned with Rick, like I realized like like you guys treat us like one of your own kind. Doctor treat all the patient all alike, but I don't know enough about doctors. It just seems like doctors prefer to get you into the clinical trial. Dr. McHugh is the same. Well, I don't know him enough, right? But I guess idea.
Look, I saw it also with McHugh and my buddy and our buddy who is getting the part before surgery, because he's in McHugh's trial there, and we are always very concerned about the academic conflict of interest, just as we're concerned about the financial conflict of interest of a doctor wanting to treat because he can make money from you. We do push people towards centers of excellence, but we always push them there, warning them that be careful of trials, because the doctors are always looking for fresh meat to push into trials. And we try to be the safety rail to stop that happening.
Yeah, so it's tough. Like right while you're waiting and the PSC are jumping and nothing they could find. Well, it's too early to see that because with today's FDG, something might be able to show up. I'm just saying, it seems like the time is on the doctor's side to get you into
Right.
clinical trial. If
Yeah. Unless anybody else has comment, it's a great discussion, and we'll have it again. But I know that Ben's pressed for time, so.
right.
Thank you, Kang.
Yeah, thanks.
Dennis, you wanted to speak?
Yeah, I'll try not to take too much time here, but a lot of the side effects from the drugs or things are starting to catch up with me. I did a little searching. I have a lot of back pain, and it seems to be getting more persistent. And as I look, I'm on Nubeca, Eligard, and Prolia. And when I look right up on all of those, they all have back pain associated with side effects. But I don't know if it's that or something else, because I also have been diagnosed with degenerative disc disease, osteoarthritis, and sarcopenia because of lack of testosterone for 8 years that I've been treating this cancer. So I'm looking, and I have, the back pain along with we talked before about leg cramps, in the middle of the night, waking me up, and foot cramps, and toes are bending all different directions, and even in my hand, sometimes I'll get it, and the fingers start going different directions and painful. I could treat these things when they occur, but it bothers me that I don't know what's giving me the pain. And I'm just wondering if a palliative care doc would help with this. And at my local oncologist here with Arizona Cancer, and they work with somebody out at Tucson Medical Center. Rick, I just wonder if you have any experience with any palliative care people out in that direction, so I can compare notes.
Well, my buddy Steve Wool does a lot at TMC, and he's not big on palliative care. Now, I don't agree with him.
Yeah.
So I don't know if that's because of the people at TMC or not. My suggestion would be to get the people at Mayo in Phoenix, the palliative group at Mayo in Phoenix, involved.
Yeah, I suppose I could probably start with them with the telemedicine stuff. And
exactly. And I would push you much more towards to Mayo Phoenix than to TMC.
Okay.
I mean, the thing is this: when you get to a certain age, which most of us are, we've all got aches and pains, and our bodies are different. Our bodies change, and I wake up in the morning and I look at myself walking, and I'm walk like an old man,
Yeah.
but I can still go out and row 12 lengths on Peña Blanca.
Yeah.
The question is whether this pain is attributable to lesions in your back or your lower back.
Because I do have them. Yeah, I do. I have them in my spine from the sacrum on up to the lumbar.
So, and when was the last time you did a PSMA?
Let's see, September
of 23.
24.
September of 24, rather.
Yeah.
So, you probably don't need, if they showed up then yes, I mean, it could well be. And if that's what it is, then you're a candidate for palliative medicine. If you want to take palliative medicine, and you need to discuss that palliative medicine, are you taking any type of medicine?
I sparingly use the NSAIDs, like a leave or something, but I got to be careful because I've had the history of intestinal bleeding or, abdominal bleeding. So I do use, instead of that, I'll do the Tylenol, and then I've used a number of like patches, stuff that Salon Pass, that didn't do
Right.
anything for me.
So let's Dr. Jeff has his hand up anyway, and I'd also like to ask Dr. Jeff what his view is on, is there a lower level, and this is also right in Dr. John's wheelhouse too. Is there a lower level pain medicine that you could discuss with your providers? We'll start with Dr. Jeff and then go to Dr. John.
So I'm on similar medications to you, and I get terrible leg cramps, um, both in my feet, calves, thighs. What I found helps a lot is magnesium spray. As soon as I start feeling these cramps, we have a little spray bottle of magnesium. I just spray it liberally, and it seems to do the job. It's been very helpful.
Yeah, that's what I use, Dr. Jeff. It's TheraWorks. You can get it either in a foam that you pump and you get a foam and rub it on my legs, and that does work good, and it also works pretty good for preventive. But it does tend to dry my skin out too, so I'm careful about using that down here. But that probably is the best thing that I found for my leg cramps. So yeah.
Any thoughts, Dr. Jeff, on if you do suffer from this internal bleeding, what sort of lower level pain meds you can
Well,
use?
you're gonna stay away from NSAIDs if you have a history of GI bleeding.
Yeah, I found that NSAIDs also can contribute to the cramping. That's a side effect of taking the NSAIDs for something else, for pain or whatever. Yeah.
But have you looked into things topically like CBDs for the discomfort?
Now, I have not looked at CBD topically.
So both there's oral CBDs, there's topical creams with CBD in it.
Okay.
I mean, if you go to a pain specialist, I'm sure they know about this. Pain management doctor.
Yeah. Okay. Yeah.
You don't have any fractures.
Lidocaine. I got a lidocaine. It's Absorbine Pro, which I think tends to work on muscles if you have the muscle pain. But to me, it's I'm almost certain it's some nerve impingement that I'm getting, either between the vertebrae or somewhere down there in that area.
Have you had any fractures in your spine?
I have not. But I'm, in this searching for the fountain of youth here, every time I get pains, I'm looking for something. And one of the things I just did recently, which turned out to be pretty stupid, was I went to this place called the Good Feet Store. And for these arch inserts, hoping I was going to get some relief. Well, they actually caused more harm than they did good. I have to wear them for 3 days. My feet were killing me. And I wanted to take them back. And then, it was expensive deal. It was like about $2,000 for these things. And so they give me a little bit of a hard time. But the last thing they said was after I complained about this, because when wearing those, my gait was off. I was losing my balance. I actually fell once in the house, and luckily I happened to be close to one of the soft chairs in the living room and landed on that instead of the tile floor. Because with my osteoporosis taking place, that would not have been a good scene. So I'm just not going to bother with those anymore.
So I have a couple of we happen to have a pain doc with us, so we're going to ask the pain doc what he thinks. But the other thing I want to suggest is CoQ10. If you're not using CoQ10 as a supplement, then it does help. It's helped me with my cramping. A lot of times people say take it with statins, and you might find it. Look into it, CoQ10, and talk to your docs about it. But make sure you don't have any interactions with it. But CoQ10 is a possibility.
Yeah, I actually used that in the past, Rick, when I was given simvastatin, and I started getting muscle pain and so forth from the statins, and I tried working with the CoQ10, and finally,
so add a CoQ10. Let's go to Dr. John and see what he says, and Steve L, and then I think we've got to move on. Dr. John.
Yeah, I'll just be brief. I mean, don't forget Tylenol. Even though everybody says, "Oh, Tylenol doesn't do anything," even if it does 10%, it might be the difference between a good day and a bad day. Also, if you want, I'll be in Tucson in a few days. If you want, we can try some acupuncture. Just call me up. I'll try to remember to bring my needles with me. So that's another good possibility. I think the CBD is a good possibility. In support of what Jeff said, my wife takes magnesium tablets, and it seems to help her leg cramps quite a bit. I think that she has restless leg syndrome.
Are you familiar with K2, vitamin K2?
I don't know how K2 would work for cramps.
That's what it's supposed to be good for.
Yeah, I've heard of it for combining with your vitamin D and your calcium for bone, but I don't know anything about the leg cramps part. Do you, Jeff?
No.
Okay.
One other thing, have you tried a back brace for your back discomfort?
I have not. I have one of those, like it's almost like a girdle, I guess. It wraps around. It's compression.
Yeah. Yes.
Did try that, you think? Yeah.
Yeah, that often takes the edge off of because a lot of times what happens is muscle spasm plays a role. You're having pain, your muscles go into spasm, that feeds into your pain. And if you put one of those elastic back braces around your back and abdomen, it takes some of the stress off the back muscles, and it might help you.
I do have one that I really never used, but I bought it some years ago before my diagnosis, and now with my Lupron belly, it doesn't fit anymore. It's too small.
Well, they make all sizes. Trade it in.
Yeah, I know. Okay.
Question. For pain, what do you think of a topical anti-inflammatory such as diclofenac?
Fine.
What was the name of it? You probably need to put it in the chat for me.
Yeah, diclofenac. It's also known as Voltaren.
Oh yes. I've also tried that for arthritis pain that I have in my joints and my thumbs and some other places, but it said not to use it on your back. It's only supposed to be used in small amounts in certain places in your extremities, your knees, and so forth like that. It's not to be used on the back. And matter of fact, one of the...
It does get absorbed also. Some of it does get absorbed.
Yeah, you can't use it with the oral stuff in conjunction with the oral stuff too. So, okay, well, it gave me some ideas. Here's some things to look into. Appreciate it.
I have a something for you. There. Have you ever heard of sensory deprivation tank? Sensory deprivation float. It's called float therapy. Have you heard of float therapy? Have you ever heard of that?
No.
So you sit in this pod. It's a pod, and it's got salt in it. There's salt in it, right? And you sit in the pod and you float in the water and salt. I've been doing that for about a year now, and I noticed that when I do it, my headaches go away, my body's relaxed, my pains go away, and when I stop, they come back. It's like almost like a salt bath, but you're sitting in this tank thing. It's called float deprivation.
I do something similar in my tub with at home with Epsom salts.
But this is a big tub where it's like it's a lot of gallons of salt. It's not just your tub; it's a big old like an egg. It looks like a giant egg thing that you're in, and you're floating in there for an hour. And what I do is I put on like some music, like some light music, and then I just sit there and relax. And I swear I sleep like a baby. I sleep like a baby up there. Yeah, you might want to try that. It's called float therapy. Float.
Float therapy.
Yeah.
Thank you.
Okay. Dennis?
Good.
Is that good?
Yep.
Okay.
Thanks
Thank
again.
you. Bob Schwartz, you're next.
Thank you. First of all, let me say to the past members and the current members, I appreciate the assistance that you provided me, and a special shout out to Len and Rick, because I did meet with Dr. Guancial, and it was better than I expected, because I had been satisfied for my first time going to a Florida Cancer Center, but going to see her was totally different, and the entire office she works at was fantastic. What happened was I've been switched off of Aberone and prednisone, and now I'm taking Nubeca, and I've been switched off of Firmagon, and I'm taking Eligard. And I know there were some questions about whether you get weaned off of prednisone. She switched me right over since I'd only been on a little over a month, and so far no negative reactions. So I'm happy with that. And what I'd like to do, I put 3 questions in the chat box. I don't know if anybody's had a chance to read them, but it says, number 1, how to prevent or deal with side effects of chemo, since I'm going to be starting chemo in the next week, and something about B6, how much and how often take, and L-glutamine, how much and how often take.
Okay. Well, first of all, I'm glad that we got proven out about Dr. Elizabeth. She's lovely. We said to you, she's lovely. I mean, she is, right? She's lovely. Did your wife like her too?
Yes, and I have to tell you, I was seriously apprehensive because I'd been to Moffitt and I was dissatisfied, and I'd been to another Florida Cancer Center office and was totally dissatisfied. But walking in there and meeting her was completely different. She is what you expect her to be, and what you and Len said she was. So I'm really thankful to you and Len, especially for directing me, even though I was hard-headed about going there, to make me go there. So I thank you.
So we try very hard to send people to docs where we know docs they'll connect with. We try really hard to do that in this group, and so I'm very pleased. Hopefully, you sent regards from Len and regards from me, and she certainly remembers Len. Whether she remembers me or not, I'm not so sure. But anyway, I use B6. I use it for my neuropathy, which is left over from my androgen deprivation therapy. I take, I think it's 1,000 a day. It's 1 tablet. I get it.
100. Probably
Sorry?
100, Rick.
100?
Probably 100.
Yeah. I'll go look in a minute when I go check on my Lubia black-eyed peas. But
Jeffrey's right, 100.
100. So that's what I use. Again, you can talk about it with Dr. Guancial because she should be open to this. What were the other 2? Glucosamine, and what was the other one?
L-glutamine.
Okay, I'll pass on those 2. Who uses? Anybody use glucosamine or L-glutamine as a supplement?
Yeah, glutamine dosing is between 20 and 30 grams a day, and it's usually broken up into like 6 times a day. So people take 5 grams 6 times a day if they're taking 30, but it's between 20 and 30.
Okay. And it helps reduce the effects of the chemo?
Yeah. But work with her on this too. She'll work with you. she's not one of those doctors who's going to say, oh, don't worry about those supplements. You're better off telling her than not. And the other thing is, I say it every time, make sure it doesn't interact with any of your other medications. Go to that MSKCC herbs and supplements website and put in glucosamine or B6 and check the contraindications.
Yes, what I did was I emailed her through the patient portal at the center where she works, and I got a response, but I don't know if it was from her or one of her assistants or whatever. And they just said, yes, they're okay to take. Didn't mention quantities or how often or anything like that. So that's how I'm trying to get a feel before I go back to see them.
Well, next time you go see her, because it probably didn't come from her, but you'll keep a list. And then when you see her next time, or you'll see her when you start the chemo, you'll ask her, Dr. G, how much do you think? And she'll tell you. Because I don't want to tell you, because I can only tell you what I take for mine. And I know I could take more. And there are times when my neuropathy is really playing up. And I'll maybe take 2 tabs instead of 1 tab. But I don't, I don't know. Dr. John, you're usually pretty good on these supplements. Glucosamine, and any input on the glucosamine and the other one?
Some people do nicely on glucose. The literature was kind of exciting at first. People combined it with chondroitin, but as the years have gone by, the literature for glucosamine and chondroitin has, I think, gotten weaker and weaker. So it's not harmful to take it, but it might not work. And if it works, fine.
Okay. Oh, and so I don't forget, I'd like to send a special shout out to Captain Jim, because he's been very helpful to me with the Veterans Association, and I've appreciated that. But this group is phenomenal, and I'm very fortunate to have found it. Really, my wife found it for me, but I'm very fortunate that this group exists, and I'm sure a lot of other people are fortunate because of it. Thank you.
Thank you, Bob. David Opp, it is your turn.
Hi, everybody. My issue is that I'm dealing with neuropathy in my feet. Started about 4 months ago on the outside 3 toes on my left foot, and probably 3 weeks ago I've been noticing some of the same feelings on my right foot. It's been 4 years since I did chemo, and I had done radiation to my L4 vertebrae in December of 22. So I'm just wondering, and the other issue, could abiraterone cause the neuropathy?
I'll look it up while you guys are talking.
Well, the abiraterone can cause the neuropathy. Yes, I mean, combination of hormone therapies in general. Are you on an ADT as well, David?
Yes, I'm on Eligard.
Yeah, so the Eligard, so it's more likely the Eligard than the abiraterone.
Okay, I've been on Eligard 3 previous times. The longest stretch was 21 months. Here, this last time, the neuropathy started at about the 18-month mark.
Yep. So the answer is yes. I have that T-shirt, and that's where mine came from. And it took a while. It actually was after, I think it was after I finished that it really started to get bad. And I just hobble around in the winter. And for me, it's when it's cold. It doesn't bother me so much in the summer. In the winter, it really bothers me, and it's painful. And I get it also in the middle of the night, which drives me nuts. So one of our former moderators suggested B6, and I started using it. It's definitely helped me, definitely. But run it past your docs, make sure there's no interactions, but try it and see if you get some relief. I think you have to build up. It's not like immediate, but I definitely would suggest it's cheap. It's a cheap solution, and and I don't know the maximum dose. I just started with 100, and
I did talk to my neurologist. She did, a complete exam, and she recommended alpha lipoic acid at 600 milligrams. Plus, I had done a B12 test, and that was on the very low end of normal. So she recommended 1,000 micrograms of B12.
How? Orally?
Yes.
Yeah. So one of the things you really have to be careful about when you're low in B12 is, are you absorbing B12? The older we get, we lose what we call intrinsic factor and acidity in the stomach. It's much easier if she just gives you an injection of B12. You bypass the stomach and you don't have to worry about absorption. So why don't you, I would ask her, can't you just give me a shot of B12?
They did do a test, a blood test that shows the absorption rate, and that was of B12, and it was in the normal range.
Okay.
And like my B6 was in the normal range also. But yeah, it's if I'm not on my feet very long, it's mildly annoying. When I'm outside on my feet for like 4 hours working cattle, it's very painful.
Have they evaluated you, David, for Morton's neuromas in your feet?
No, they haven't.
So that's an easy thing. You can get an ultrasound, but Morton's neuromas can give significant discomfort, 3 toes, usually the third, fourth, and fifth toe. And it's a nerve tumor. It's not malignant, but it's a compressive nerve tumor. So Google Morton's neuroma and foot pain.
Okay. Now they did also, the neurologist ordered EMG on it, and it did come back showing neuropathy in the left foot greater than the right. That would be all I've got. Had a question on tonight.
Thank you, David.
Yes.
Dr. Jeff, it is your turn.
I just want to relate a quick episode. A few weeks ago, I went for a Lupron shot. I've been getting Lupron for every 3 months for a while. An NP gave me the shot. I did not see the physician. And as she was giving me the shot, it was kind of uncomfortable, unusual. By Saturday morning, I was in extreme pain, so bad I couldn't get out of bed. I could not get comfortable. It was like an overwhelming pain, kind of similar to the pain I had in the beginning when I got Firmagon in my belly. But what happened about 6 o'clock at night, I developed a fever to 103. I was a mess. Got up, tried to go downstairs, almost fainted. Pain was ridiculous. And I just went to bed. Wasn't sure whether I was going to get up on Sunday. Thank God I did. And I notified the doctor. They wrote me back, oh, it's good you're feeling better, which I was, comes Monday. And I made a request and I said, look, I don't know who gave me the shot. I don't know where they put it. However, I don't want Lupron in March. I want to switch to Orgovyx PO, and I haven't heard back. Obviously, we all know you need your doctor to contact the insurance companies, the specialty pharmacies to allow the switch. And if it's more expensive, they usually say no. But if they tell me no, I'll buy it myself because I told them there's no way you're giving me another Lupron shot in March. You can give me Prolia, but no Lupron. No more injectable blockers for me. So I don't know what happened. She doesn't know what happened, why I got that fever for 12 hours. But I don't want to ever do this again. Especially I'm on the last leg of this 2-year nightmare, and I want a soft landing when it comes to finishing. And I think Orgovyx is fair.
Is it your doc at
MSK
SKCC who's giving you the shot, or
it was an NP this time?
Yeah, but it's MSK. MSKCC should be able to justify the Orgovyx.
Yes. Now I'm waiting. I haven't heard back. But again, if they won't approve it, if they won't do it, they won't approve it. I'm just going to buy it for 5 months.
There's a lot of guys in this group who are getting Orgovyx. So, it shouldn't be that difficult, Jeff.
I'm asking.
And if not, we should push them. And especially since you had an adverse reaction, all the more reason.
Right.
Can I just say one quick thing to David Opp before, and then come back to Jeff? We forgot to mention there are other good things for neuropathy, one of which is acupuncture. So, that's just something else to think about, trying to use acupuncture as another alternative. So, yes, Jeff, anything else other than no?
That was enough.
It was enough. It was enough. As to keep in the spirit of this whole meeting, Diana. Okay. All right. And I loved your message. I loved your message in the chat. You should send that message to Etan as well.
Okay.
Luther, are you with us?
Yep, I'm just in the kitchen. Let me turn the camera back on. Okay, I just wanted to update. So I finished radiation therapy 2 weeks ago yesterday.
Yay!
Yeah, I'm done, and I'm done in 2024. So this stupid year is over. Fatigue dissipated almost instantly. That was the main side effect I was having. I'm also on doublet therapy. I've had a lot of good days in the last couple weeks. Just got back from the mountains. Stamina is still kind of down, especially with exercise. The heart rate tends to go up and stay up way easier than it should. Although they cautioned me today, expect a couple months for full healing, etc. So just that quick update. I'm done. Unless something really bad happens in the next 18 months while I'm still on doublet therapy. But
okay. Well, we love that. And I hope you're treating yourself to a steak tonight for New Year's Eve.
We already did that. We were in a mountain town called Sun River, Oregon for the past we've been living it up all week. So we're cooking at home tonight. We're done with alcohol for now. So I'm just putting carrots in the sous vide and cooking some chicken.
Good for you. That's great news, Luther. Hopefully you'll continue to feel better, and the doublet therapy is tough, and you just got to keep pushing on that exercise like you've been doing and watching it, but keep coming back here. It's great to see you in this meeting just as well as it is in the under 60s meeting. So.
Yep.
And
you can feel pretty good on hormone therapy. I'm 5 months in, no major issues.
There you go. Thank you. Well, we got two of you, Joe Commander and you. So it's you guys are great examples. I will voice what Mark Valens put in the chat for Joe, for David Opp and other neuropathy, that CBD salve massaged into the feet and lower legs gave him a lot of relief. There you go, Dennis Correa. See that? See the CBD salve? So, and just whilst I have the floor on Mark Valens, and I did ask Mark beforehand. Mark's been having a really rough time because he went through 2 chemos and that seemed to do a number on his immune system, and he managed to come up with RSV, a UTI, and some other stuff that I can't remember off the top of my head, although I do have them related. So wound up in the hospital last week, lost his voice, is out of the hospital, and hopefully we're going to get, and didn't do the 3rd chemo on schedule, so they pushed that up, but hopefully we're going to get him back into his old self pretty soon.
Yeah, feel better, Mark.
I guess there must be a game. I'm not keeping up with the college football this year. Tomorrow, who are they playing, Dr. Jeff?
Is it Ohio State?
Yes. Ohio State. I know ASU's got a game against Texas, UT. That was either today or tomorrow. I don't know.
I think it's tomorrow.
Tomorrow. I'm trying to keep up with the Premier League because they have matches all over the place right now, and it's I'm having a problem with that, so I haven't. But on for Mark Valens, go Ducks. All right. Back to you, Ben.
Yes, Steve Al, you're up next.
Okay. Well, my first and only previous PSMA was a gallium test almost 3 years ago, and now I'm scheduled for a Pylarify, and I see that it's slightly different. I was wondering if there was any difference in interpreting them, one following the other.
Oh.
Has anyone had a Pylarify?
Oh yeah.
PSMA?
Yeah.
Yeah, Ben, come on. This is in your wheelhouse, man.
You know, any competent reader of these things is going to know the differences, the vagaries of each one, and be able to roll with the punches. Yeah, they are different. They're interpreted differently, but it's the kind of thing that's what you pay the doctor for. They should be up on this if they're giving you those scans. Lots of people have had Pylarify scans. Lots of people have had both.
At the beginning, in the beginning, since it's 2025, we can go to biblical references. So in the beginning, the Pylarify test seemed to be a little more sensitive and tended to give more false positives. And so there were a number of docs who preferred not to use Pylarify and tended towards Locomets, the gallium, and the other, I forget the other name, but the gallium test. It seems like that's gone by the by now, and it seems, just as Ben said, that the doctors are much better at reading these scans, so they discount any differences, any variances they see in the scan. So I think at this point in time, it's not a big deal. But for the first year or so, I think there was some concern by certain doctors over Pylarify.
Okay, thank you, Steve. Artie McNeil, you're up.
Oh. So I was kind of laughing when you guys said something about the doctor's push towards trials. So this is what my hematologist wrote me. I asked her about community care because I wanted to go to UCSF. And she said, doctors. And she wrote this. She said, I gave you a call and left a message so that I could clarify community care is meant to offer care, is not offered at the VA. I only can community care if it's not offered at the VA or if it's over 100 miles an hour away from your closest VA. The only way we could the only way around this I could see is if we send you to clinical trial evaluation. If you're willing to consider this, we can try that under that pretext. So when she wrote that, I immediately went to what you guys were talking about the doctors trying to push you to the trials. I'm having an issue with trying to get community care, even though I have community care, I'm going to radiation. I had a PSMA scan done, and I found there was some in my clavicle and a little bit in my lymph nodes, but my lymph nodes isn't detectable, I guess, but my clavicle is, and they want to do radiation on it. And I find it interesting that I'm approved to go outside the VA for the radiation, but I'm not approved to go outside the VA to get a GU oncologist. I find that so I'm having an issue trying to get the GU oncologist. They have one. They gave me one for Palo Alto, Rick. Her name was what's that right here? What was her name? Oh, Dr. Divyaplarikh in Palo Alto. And I remember you was telling me about try to avoid the GUs in Palo Alto. I mean, you said it's okay, but that's the only option.
No, I said to you last time in the meeting, Artie, that I would go to the GU medonc in Palo Alto. I'd prefer her than Amy Lynn. Oh, did you say to me Amy Lynn's not seeing patients anymore anyway at San Francisco?
They don't have no GU at San Francisco no more. There's none.
So just take the appointment with at the VA at Stanford.
Yeah.
She's probably a Stanford doc. I thought that there was somebody with that name at UC Davis. She could be the UC Davis doc. Just spell her last name for me again.
P A. Let me get it right quick. What was that? Parikh.
Yeah, Parikh. I thought she was at UC Davis, but she could be at UC Davis, and she could be, quite easily going down to Palo Alto for the VA.
Yeah.
But let me just look in, because the name sticks in my mind. Parikh. Parikh. All right, so let me look for her. But yeah, I think that's what I would do. I'd just go, just forget the community care.
I do have an appointment with her on 8th. I made the appointment with her.
Okay, so don't knock yourself out.
Yeah.
Good.
Yeah.
Right, Mr. Captain Marshall?
Yep.
Okay, then my other question is, I know standard of care. Well, I'm not sure. I don't know, but I'm thinking. This is what I'm thinking now. I'm wondering why I didn't get this. So I'm waiting to get my somatic testing done. I did germline. It's not hereditary, and I'm waiting for somatic testing. But my question is, why don't they do somatic testing first before they give me all this other stuff to find out what works? Because this other stuff they gave me, none of this worked. So why wouldn't they do? Is there a reason why they wouldn't do somatic testing first instead of doing the practice the surgery, the hormone treatment, the radio, did all that stuff and nothing worked? But I still haven't had my somatic testing yet, so I don't know what that's going to be. Why wouldn't they do that to begin with, to start off with, to see what would work for my body, instead of making me go through all this other stuff first, which didn't even work?
I don't know.
Is there a standard of care they have to do that route first?
No. So they're supposed to give you, first of all, they're supposed to do the germline test when you first get diagnosed. If you're at least, I think it's a 4+, if you're high risk, it might be also unfavorable. I can't remember. And if you've got anything in your family, that's now the guidance. And they're supposed to do a somatic test as soon as they see that you're metastatic. Those are the clinical guidelines. My guess is that they did the germline before they knew you were metastatic. And now they're doing the somatic because you are metastatic. Now, there are some people that present de novo metastatic, and they'll do the somatic test first, and if certain mutations show up, they will then do the germline to make sure that they're not inherited. Because if they're inherited, you need to make family members aware.
No, it's not inherited. They told me I'm not inherited.
Okay, so why didn't they do the somatic earlier? Because your disease wasn't advanced enough to warrant it.
Okay. Well, the other thing also is with the radiation, right? With the radiation, is that the route? Like, so they want me to do radiation. Are there other, like, what will the somatic testing show? Can the somatic testing show that I would need something else besides, I can use another modality of care instead of the radiation, or is radiation first and then the somatic can tell me like what other little things I have to take with it or whatever, like other little like if I do hormone treatment or all this other stuff. Like, how does that work?
So the somatic test may indicate other treatments that might be available to you beyond the standard of care. So we don't know what those are until we get the results of the somatic test back. It may well be it won't make any difference. There are also some mutations that make your body more sensitive to radiation. So it might change, it could possibly change the radiation doses, but that's unusual, but it can happen.
Well, I'm gonna wait until I get my somatic testing back before I do anything. But I am going to talk to the radiation doctor. I'm not radiation. I mean, I do have an appointment with the radiation doctor and the GU. I have an appointment with them. So.
Yeah, I mean, the radiation doctor's most likely going to say to you that the somatic test won't make a difference. And if they did, we wouldn't be surprised, but it can make a difference. And it's because it's controversial as to how these mutations affect radiation dosage. But it is thought that they do affect radiation dosage, but don't expect your radonc to sort of be particularly enthusiastic about the results of your somatic test. The GU medonc maybe. I mean, I'm looking at Dr. Parikh's resume right now. She is a GU. She's definitely a GU. She's got a very nice smile, so I like her right away. You know, I think she's fine. I don't really know where she did a fellowship at Stanford. I don't know where she trained. It doesn't say on here. Oh, she did a residency at Stanford. Oh, she went to BU and then she did a residency at Stanford and a fellowship at Stanford. You know, and she's a GU medonc. Yeah, she's got a decent background. I think you're good with her. Given, you know, unless we could get you out and get you to see somebody at UCSF, that's a good second best.
I want to ask Captain Jim, if they're denying you Well, it's the hematologist. It's not really community care denying me. It's the hematologist saying that they're not gonna. She not me put the referral in because she's saying they're not gonna approve it, but she won't put the referral in. So can I go like above her head or try to go to like patient advocate or talk to somebody, see if I can get somebody else to maybe to get to put the referral in? Because I want community care deny me, not her saying, you know what I'm saying? I want them to deny me, not her.
Well, anyway, I would try it, but she said something about they will not refer you over 100 miles away.
No,
right?
if it's under, no, that if it's got to be over 100 miles for them to refer you. And Palo Alto is 100 miles away.
I don't think it's 100 miles. I thought it was only 40 miles.
I'm in Roseville. I'm past Sacramento.
Well, I don't know where you are, but the limitations, I think, on community care is 40 mile. Or if you're, well, I'm not quite sure. So yes, I mean, you can go ask anybody. It's up to you.
Yeah, I'm just curious why they're denying me.
I have no idea.
But the other stuff,
the best thing to do is take a tree.
All right, man.
Government workers, you can shake them up real easy.
Yeah. Okay. All right. I guess that's all I have then.
Thank you. And it is your turn, Jim.
Okay, it's awfully late, so I don't know if everybody wants to hang around or what.
Just keep going. People will drop off and
keep going. I got a story here.
Try us, yeah.
I will try to be brief. The story is I was on treatment for 5 years, abiraterone, Lupron. I'm on a 28-month holiday. The PSA is just starting to rise. It's been at 0.06 now for 3 months. So I started to look ahead thinking that I should get a PSMA PET scan. I'm a Kaiser person. So I talked to my doc on oncologist, and she says I have to go through a CT scan and a bone scan first. I don't understand it. So at that point in time, I contacted my primary care in the VA, got a referral to the oncology, told them I wanted to see a GU medonc. Eventually, they said, okay, I've got that. So in the meantime, I took the CT scan and I took the bone scan. Good news, the bone scan is clean. The CT scan shows a small mass on the left kidney. What that means, I'm not quite sure. So I get referred to urology. So I got a list of 1 urologist and 3 physician's assistants to talk about this mass. So I selected a PA, okay, on purpose. So I talked to the PA and I expressed my concern that it could be prostate cancer, and the easiest way to find out is to get a PSMA scan. And the urologist says, that's easy. I will refer you. So I got one scheduled on the 16th through urology, not through oncology, or on the 15th. And then I've got a VA appointment to see their oncologist to try to get to community care, Channing Paller. So as I said, now, Rick, I got a question for you. This is a little outside of this. Okay, a small mass.
Let's just, before you go to your question, let me say that was brilliant on your part, Captain Jim. Brilliant. And the reason it was so brilliant is because I don't think I've ever heard of prostate cancer metastasizing to the kidney. I don't know if it does, and maybe one of the docs on here would contradict, but I don't think it ever goes to the kidney. I will tell you that a kidney spot saved my life, because I had a little spot on my kidney that they monitored for 4 or 5 years, and I had a PCP at Kaiser who refused to do PSA testing. I had a terrific urologist who I still think is great and recommend. And he said, we better check your PSA. And they found that my PSA had risen and it was at 10. And if it hadn't have been for that kidney spot, I wouldn't be here today. I'm sure of that. So, and I will also tell you that my friend Stevie Wool, who I mentioned before, who's on our advisory board, said if he had a dime for every kidney spot that was benign, he would have been able to retire many years ago. So most of the time, these kidney spots are benign. Not always, but most of the time they're benign.
How big
Okay,
is
he
the mass,
said,
Jim?
according to the CT scan, it was about a 1 centimeter mass.
Right.
Now I don't know if that's big or small or what.
1 centimeter is very small.
Yes.
I bet benign.
Yes.
Okay, but the PA tells me there's 80-20 kidney cancer. But you're telling me that it's probably the 20/80.
It's 20. I would say it's 20/80 or less, and I would say that they don't know if it's a mass or it could be a cyst.
Right.
So if they're saying mass, that's wrong. It could be a cyst, and I would say that the PA needs a little more education because 80-20 is not what I've heard from any good GU, any good physician, and certainly in any GU doc. They'll tell you the reverse. And look, even Dr. Jeff is shaking his head.
Okay, because the PA's referring me to a urological surgeon, and the choices are wait and see, ablation, and surgery. So I'm just trying to figure out.
I can only tell you what I did. I followed my mass was started off at about 3 or 4 centimeters, and then it went down, and then it got bigger, and then it went down, and eventually it got down to under 2, and I stopped even watching it. But along the way, I found out I had stage 3 prostate cancer. Thank God.
Okay, good. The info, because
hold on, Dr. John, did you want to say something about this?
There's a difference between a cyst and a mass in terms of their malignant potential. And it's easy to tell the difference on the imaging. And that may be why there's some confusion and differences of opinion. A solid mass has a different potential than a simple cyst that doesn't have separations inside it. So do follow up.
Yeah. Okay.
I think what John is saying is go back and have Kaiser confirm it is a mass and not a cyst.
Yes, I will do that. Now, just a question. I didn't know if I should be attending the RMC group to talk about this.
No.
No. Okay.
Okay. RMC is a completely different type of kidney cancer.
Okay.
It's caused by sickle cell trait.
Oh, okay. No, I don't have that.
And it's not something that you even want to go near. Right. And the answer is no. You're very welcome to attend if you want to listen to them, but your condition is not related to theirs.
Okay, and the last thing I found out for the folks in the Washington area, the Washington VA has a community care agreement with Johns Hopkins. So that's their preferred provider for community care. Which
makes Channing Palla all the more readily available.
Well, I'm hoping that when I see the VA cancer doc, that I will be referred over to her. And that will be my choice. So,
Okay.
That's it.
Do we have anybody else? If not, I want to talk to Doug.
Yeah, there's he isn't on the call. It's David Vander Els.
Yeah, no. That wasn't my question. My question was to Ben. Do we still have anybody else, Ben?
Oh, right.
We're at the end of the list.
Okay. So let me talk to Doug because he put in something in the chat window. And if you have that referral in an email form or in a confirmation, you can do a screenshot off of your. I mean, is there's nothing in writing? There's got to be something in writing, Doug.
No, she just said she would refer me, and I suspect that they will call me back and tell me that I have an appointment.
Right.
I don't know how VA works, but that's how it's been with Kaiser.
Okay, so if the PCP is referring Doug, Captain Jim, where would we see written evidence of that?
There would be an email that will come to you that will have the referral on it.
Okay.
So there should be an email out of the VA.
Okay. Look
That's
for
what I was
that.
expecting.
Look for that email, forward it on to us, and we'll forward it to Mike Crosby, who has a very good relationship with Julie Graff, and we will try to make sure she sees you rather
Fantastic.
than one of her colleagues.
And the lady I talked to knows her well and was going to try to get me to her. Anyway,
Right.
I shouldn't really have mentioned that bad news because it's not really bad news. I think I'm going to get her or one of her immediate colleagues.
Okay, well, the issue is whether her immediate colleagues are GU docs or not.
Right.
And that's what we don't know. We know Dr. Graff is a GU doc, but I think what you have to say to the PCP is, I only want to see a GU medical oncologist. This is not about getting you to a medical oncologist. It's about getting you to a GU medical oncologist. So I would go back through the portal, the VA portal, and say, tonight, I just want to be sure if I don't see Dr. Graff, it will be a GU underlined medical oncologist.
Okay, I will do that.
Okay. And notwithstanding, if you send it to me, I think we have a good chance through Mike Crosby of getting you to see Dr. Graff.
Fantastic. I did. You mentioned several other doctors also, and I did mention two of them. I mentioned Dr. Vuki. Vuki. Right, Dr. Vuki and Dr. NG, however you pronounce that.
Yes.
So I mentioned those to her also, so I'm sure she's got the idea, but I will wait for that email and
I mean, frankly, I'd rather you saw Dr. Vuki than you saw Dr. Graff. If it were me, I'd rather see Dr. Vuki than I would Dr. Graff.
Wow, okay.
Okay.
I think I'm in good hands. We'll see.
Okay.
And thank you very much for all the encouragement. And I really appreciate this group. I'm sure we all do. Glad I found you.
We're glad you found us.
Good job.
Yes.
As you know, I used to see Dr. Vuki for 2 years plus, but then, or maybe 3, and then she went into research with Dr. Beer, and then I was referred to Dr. Julie Graff, and I have an upcoming appointment with her on the 14th of January. She missed the last appointment, and I had to see one of her assistants. But as you know, my PSA and everything is very, very low at this point, so I wasn't so concerned. But my understanding is that after talking to the assistant, that Dr. Vuki is not seeing patients. She's totally involved in research, so I'm not sure.
Okay. But she's very good, isn't she? Didn't you like her?
She unbelievable. Unbelievable.
Yeah. And I think Dr. Graff is good too, but she's not quite as stable, shall we say. So that's why I would go to Dr. Vuki if I had the choice, but if you can't get to her. Now, meanwhile, Gaoshan, now that you've emerged, Happy New Year. I understand it's already 2025 in Shanghai.
Yes, it is. It's already 9:40 in the morning.
Okay. How was your New Year's Eve?
I stayed up till just after midnight after having dinner with a friend and went to bed. That's it. Nothing, no drinking, no partying, no carousing.
Okay. Is it a big deal, or maybe I should ask Kang this? Is New Year is this New Year's Eve? This isn't Chinese New Year. This is Kang? How big a
It's
deal is
minor.
this New Year?
Go visit China.
Minor.
Go visit China. Spend a New Year Eve there.
What about your opinion, Gao Shan?
One New Year's Eve and New Year's Day. I mean, it's minor compared to Chinese New Year, of course.
And I already know what the answer is in Israel because I've actually been in Israel for New Year's Eve, and it's like they hardly even notice it. They don't. There's too many. There's 4 New Years in Israel, isn't that right, Etan?
Yeah, so we just imported, well, just the past 20 years, we imported over 1 million, I think more like 2 million Russians.
Yes.
And they love to celebrate New Year. So it is a big, it's become a very big deal indeed.
I see. Okay. I was in where was I? A couple of years ago. Where's the but it's between Herzliya and west of Herzliya. No. East of Herzliya. Not Ramat Gan. Oh, Ram. I can't remember. Doesn't matter. But anyway, that's where I celebrated New Year's Eve with my cousins a few years ago. It's just gone out of my mind. That's what happens when you get old. Can't remember anymore. All right. Mr. Fish, everything okay with you? You came in late. Anything you want to tell us? You're muted.
No, I'm fine. I was here and I left to have dinner and came back.
Oh, how was dinner?
Good. Steak.
This is what we tell our guys. It's every once in a while. Etan, you should know. We tell our guys every once in a while, blow out, enjoy yourself, have a steak meal. So they're all doing it on New Year's Eve. So to make themselves feel better.
Yeah. No, I'm not steak adverse.
What does Dr. Audio say about that? Anything?
We don't discuss it. I don't give her up to discuss it.
I am surprised. And the place I was trying to think of was Ranana. That's where I spent it, in Ranana. So
you're in Ranana?
Yeah. I spent New Year's Eve in Ranana maybe 6 or 7 years ago.
Yes, very nice place.
Yes. So that's where my cousins live in Kiryat Sharet. My cousin lives in Kiryat Sharet. So anyway, anything else? Mr. Ben, anything for you?
Nope. We live to fight another year.
Okay. I hope it's all a very happy, healthy year for everybody here. And we can keep doing what we've been doing. If you haven't filled out the survey, let me stick the survey in the window quickly, and you can click on it. As I was going to do that right at the beginning, and I think I forgot. But here's the survey. I think we're trying to get to 400, and we're close. So there's the survey link, and like I said, I know some of you folks have already made the donation. Those of you who are new don't know this, but we only ask once a year, and we don't bombard your box just like other people do, but this is the time of year. So, all right.
See y'all next year.
Oh, yeah.
Happy New Year.
Happy New Year, everyone.
His voice is coming back. Happy New Year, everybody.
Good night.
Good night.
Happy New Year. Shin Kuala.
Happy New Year.
Yeah. That